Thanks so much. We're very pleased to have the Amit Saindane, who is the professor and interim chair of the Department of Radiology here at Emory University. By training, he is a neuroscientist and neuroradiologist. He has a lot of collaborations where he is working with Emory Neurosurgery, Emory Neurology, Emory ENT, and we are very much looking forward to his approach to thinking about and looking at what to image and when in terms of thinking about your patients with cognitive impairment. So thanks so much for coming. We really appreciate you.
All right, well, thanks so much for the introduction, Ted, and Ted, Gabriella, Lori, thanks for the invitation to speak. I'll go ahead and share my screen here. And all right, so I'm really excited to talk to everyone about the imaging findings in dementia and some of the common entities that we come across in radiology on a daily basis. First of all, I have no relevant financial disclosures or other disclosures related to this topic. And the learning objectives here, first to compare the imaging findings of common causes of dementia, and I will present these in unknown format for folks to type in their answers in the chat or unmute themselves, hopefully to make this fun and interactive. And then to be able to determine the optimal imaging approach to the workup of dementia. And I will go through some of my thoughts on imaging modalities, contrasts, strengths and weaknesses of the various approaches. Important to keep in mind, and I teach this to our trainees, that the role of imaging in the work of dementia is not to say whether a patient has dementia or not. That is not for the imaging to say. That is a clinical diagnosis. What we are doing is characterizing the overall brain structure, whether there's brain atrophy, whether there's white matter ischemic disease, excluding any kind of surgically treatable cause. And I'll present a few of them today. And then finally, to detect abnormalities that may suggest a specific diagnosis. And there are relatively uncommon entities where the findings are very specific on imaging and can really help with the diagnosis. All right, so I will start with the first case. And this is actually two different patients, patient A and patient B, that share a similar diagnosis. So if anybody wants to unmute and chat out, or actually I can't see the chat.
We'll watch the chat for you.
Okay. If people have thoughts on a diagnosis here.
Give you a second to just type something in. Go ahead and hit send and we'll look for your answers. No worries. Yeah. We're just looking for engagement. We're all going to learn something here. So if you're not sure, just go ahead and type it in. We have a vascular dementia. You have a nod about vascular dementia. Any other answers? Mixed dementia.
Sure. Okay. Good. I mean, I think that's a great start here. I'll describe the findings, which I think people have really captured here. So this patient A has large middle cerebral artery distribution chronic infarctions on both sides. So it's a little tricky. It's bilateral, it's symmetric, with some gliosis around this encephalomalacia. And patient B has a lot of this deep white matter T2 flare hyperintensity, which is microvascular ischemic changes on a chronic basis. So these are actually both examples in the correct clinical setting, of course, of vascular dementia. And this can take various forms. So it can be multiple cortical infarctions, like in patient A, a lot of lacunar infarctions, chronic microvascular ischemic changes, like the image for patient B, or a combination of these. So it is not necessarily just one form of ischemia. It may be related to embolic infarctions, maybe lacunar infarctions, chronic small vessel ischemic changes. And I wanted to spend just a moment talking about small vessel ischemic changes because this is, as a neuroradiologist, the most common finding that I report on any kind of imaging, hands down. And it is a finding that is so common that it's almost a normal part of aging. We see a little bit of this small vessel ischemic changes, usually on a T2 flare sequence, such as these, and just these little bright dots. They may be in the deep white matter, they may be in the subcortical white matter. And so particularly in imaging a patient for dementia, typically an older patient, we're going to see this very commonly. And so the Fazekas scale, which is commonly used for grading microvascular ischemic changes, mild is when it's really just punctate, moderate when it's equally punctate and confluent, and severe when it is almost entirely confluent. So that's the scale that we're using when we describe this. So when you see a report come across and it says mild microvascular ischemic changes, that's what we're talking about. And if this is an elderly patient, it's it's going to be incredibly common and probably unlikely to have a totally normal brain. If you've got someone in your 80s, 90s, not to have a little bit of this. But when you start seeing things like this is where you may start to think that there's a vascular component to the dementia. When there's this, or you're seeing cortical infarctions, lacunar infarctions. Great. I'll move to the second case here. And I can see the chat now, so happy to look out for answers.
So go ahead and feel free to type in an answer, something that you observe on this image that makes you think of a certain diagnosis. No fear of being wrong here. We're all in a learning environment. Give you a couple more seconds to type something in. Yeah, you could type in 3 letters and that'll be easy.
Right, and we've got the long form as well.
Great.
So wonderful, and you both nailed the diagnosis here, normal pressure hydrocephalus. The findings that I'll point out here, so the ventricles are markedly enlarged relative to the sulci. So we can see this in the axial plane for the lateral ventricles. We can see this in the coronal plane for the lateral ventricles. The third ventricle is ballooned out. Usually the walls are parallel, and the temporal horn is markedly enlarged here. So in continuity with the rest of the lateral ventricle. And then one of the other tip-offs that we don't always see is this alternating pattern of enlarged sulci and compressed adjacent sulci, these so-called external reservoirs of CSF that are found sometimes in normal pressure hydrocephalus. So excellent, you all are nailing.
Does that diagnosis give you trouble when it's a little more subtle?
Absolutely, and that's a great point. This was sort of a slam dunk. The fact of the matter is that in normal aging or due to a variety of neurodegenerative conditions, the ventricles can get big. And most of the time that is on an ex vacuo basis. That means the brain around it degenerates and the ventricles get big. And so it can be sometimes a gray area, and that's when we're not so sure whether we're dealing with just atrophy and enlargement of the ventricles or hydrocephalus. The things we're looking for here, and I'll show you a couple of slides, some of the findings we're looking for that would point to NPH rather than just brain atrophy related.
And Dr. Hales typed in that the hippocampus looks small on the coronal as well, suggesting that NPH is not protective of every pathology.
Correct. So normal pressure hydrocephalus, this is the clinical triad. Wanted to focus on some of the imaging approaches to making this diagnosis, either on CT or MR. One is calculating an Evans index, basically looking at the size of the ventricles to the size of the internal aspect of the skull. And so the idea here is that as the ventricles get big, this index gets larger. Another way of looking at this is the callosal angle. So the angle between the lateral ventricles in the coronal plane. And the idea here is as the ventricles get bigger, that angle gets smaller and closer together. Normally it's about 110, 120 degrees. But yes, this can be a little bit tricky when it's not quite so florid like this. All right, case number 3, and you all are batting 1,000 so far, so keep up the good work.
Feel free to type in an answer in the chat. Learning environment, no penalties for wrong answers. You can only score a point if you answer.
All right, we have subdural hematoma. Great. All right, so yes, this is a chronic subdural hematoma, and so here's a collection along the right hemisphere. It is pushing on the brain, and here's where the midline should be. So here's septum pellucidum, and here's sort of where it normally would be. So we can see the brain is shifted over to the left because of this large collection. It is not as dense as we would like to see acute blood. So likely this is a collection that happened a while ago. The blood liquefied and is causing this mass effect. And so this is one of the things that we're looking out for, because patients may present with neurological complaints or may present with cognitive complaints from this. And this is something that is potentially a treatable cause through drainage of the subdural. So excellent job. And this could be, so the options, a hygroma or a hematoma, sometimes difficult to tell. This has some hyperdense components in it. So likely was a hematoma that liquefied later, but hygromas can happen just from a tear in the membrane that allows CSF into the subdural space. Or it can be a hematoma as the result of a fall that eventually liquefies and it looks more like fluid. All right, that was case 3. All right, we'll move to case 4, diagnosis on this axial T2 MRI sequence. We have intracranial mass. Any other thoughts before I move forward? Well, that is absolutely correct, and I don't know that we can take it that much further just on this sequence alone. But here we have actually a mass here and probably a second mass over here with some surrounding vasogenic edema. It is causing a little bit of mass effect on the right lateral ventricle. And we would, in real life, look through all the sequences, see if there's any clues, see if there's a known diagnosis of a primary cancer. And the big differential here would be metastatic disease, if we believe this is 2 lesions, or a primary brain tumor that has sort of a satellite lesion here. But at the end of the day, intracranial mass, and in this case, it turned out to be a brain metastasis in a patient who didn't have a known primary malignancy. And so that can happen. This is a situation where we don't have a specific diagnosis, but we can suggest that we follow this up and do additional workups to try to figure out whether this is a primary brain tumor or whether this is a metastatic focus. Great. We'll move to case number 5, diagnosis based on this coronal T1 with a color overlay. All right, jumped on that really quickly. Alzheimer's disease. Excellent. And that is exactly right. So a shrunken hippocampus here, so we can see the hippocampus here is outlined in yellow. We have enlargement of the temporal horn, and this is actually quite large relative to the rest of the ventricles. And so that's a tip off here. We have sort of an internal reference that this is a normal looking set of lateral ventricles and third ventricle, but the temporal horns that should be really, really small and slit-like under normal conditions are way too big, and the hippocampi are far too small. In this case, looking at the entorhinal cortex, the parahippocampal gyrus, we're not seeing a ton of atrophy here, but those are some other signs that we're going to be looking for to help point us towards this diagnosis. Enlargement of the collateral sulcus. I'm not showing that anatomy all that well on this one slice, but if we saw something like this on an MRI or on a CT, we would say that the mesial temporal lobe structures are atrophied, and this may suggest a particular form of dementia. Again, we're not going to make that diagnosis based on the imaging, but we can certainly suggest what parts of the brain are predominantly atrophied. And we have a variety of ways. You may see in some of the reports different scores. There's mesial temporal atrophy scores, entorhinal cortex atrophy scores, the ERICA score, or volumetric analysis. There's some variation in how these are reported out depending on who's doing them and where they're being imaged. But really looking out for temporal lobe volume loss, some parietal lobe cortical brain atrophy, and the precuneus and some other areas in terms of the findings. Move to case 6. Suggestion on a diagnosis. And a great point about when evaluating the size of the ventricles, putting in the context of the patient age. Yep. All right. Well, they're all over it today. This is great. So focal anterior atrophy, frontotemporal dementia. Okay, good. I think everyone's on the right track here. And again, from the imaging standpoint, we can describe where the brain volume loss is most predominant here. And I think this is a pretty striking case. So we're seeing the frontal lobes are shrunken. We can see this in the inferior frontal lobe, as well as the temporal lobes, but really a preservation, parietal lobes and occipital lobes. And we're seeing this ex vacuo enlargement of the frontal horns here. And so this is frontotemporal lobar degeneration. This is not a specific diagnosis from the imaging standpoint. It is just to say that here's a striking pattern of volume loss that is abnormal and that is focused on these specific areas. So if it fits with the various clinical disorders that are frontotemporal dementia or degeneration, that is the idea here, but not necessarily to, based on the imaging, say that this person has this type of dementia. All right, last case is based on these diffusion-weighted MRI images. So diagnosis, please.
You might want to point out some hints and where to look in this one.
Oh, sure. Yeah. So this is a diffusion weighted image. So we're looking for abnormally bright signal, and we're seeing it along the cortex of the, this is going to be the cingulate gyri if we were triangulating this on a sagittal. And we're seeing the caudate, the putamen, and the thalami that are too bright. And if we correlated this with the ADC map, which is a calculated map that actually quantifies whether there is diffusion restriction or not, it would be dark on that map, and it would show us that there is diffusion restriction in the cortex and these deep gray matter structures.
We quickly went to graduate level neuroradiology. You have a couple of answers in the chat if you wanted to look at those.
Yeah, and all over it. So prion disease and suggestion of a pulvinar sign. So we did get advanced here, and this is CJD, or Creutzfeldt-Jakob disease, prion disease. And so this is actually prion deposition, spongiform degeneration of these gray matter structures. There's various clinical subtypes related to the etiology, clinical triad, myoclonus, progressive dementia, specific pattern on EEG. And this is really the sequence on MRI, the diffusion weighted images. I'll just go back to that now that I've pointed out the areas. That is great for this. You can also see these same signs on a T2 weighted or a T2 flare type of sequence.
This is a great image to think about when you as a radiologist look at the clinical history that's provided, because this clinical history shouldn't seem or feel like any of the other clinical histories that were provided. And so is it often that you get enough clinical history? Is it often that you're looking at that after you do your interpretation? Thanks.
Yeah, no, great question. And I think maybe one of the take homes from this that I'd like to impress on everyone is the more information we get coming in, the better and more helpful we can be as radiologists. So it's rare that we're going to get periodic sharp waves on EEG. We're looking for CJD, but if we got that, we would be very much more highly attuned to this. And I'll say that there are examples of this that I've seen that are only involving the cortex, and without a history that's very suggestive, that's something to very easily blow by and miss. And so whatever information you can provide up front that is helpful towards making a specific diagnosis or helping with a differential diagnosis, the more helpful we're going to be in terms of the output. All right, so great job on those cases. I wanted to talk a bit about the workups and modalities and contrast. And so relative strengths of CT and MRI. So CT is, it's fast, it's less expensive. So in general, in terms of the cost for it, modern CT, it used to be that you didn't have multiplanar CT, so you couldn't see the hippocampi well in the coronal plane, or you couldn't see the sagittal plane. Modern CT is a volume acquisition, then you can slice and dice it into any plane. So that advantage of MRI has gone away. And then, on the disadvantage end, and maybe before I get to that, the faster piece of it, if you've got someone who's really not going to cooperate for a 20-minute inside of a narrow tube examination, I think CT becomes a pretty darn good choice there, because that's generally a wider bore and just being in the scanner for like a couple of minutes. And so most people can get through all that without any sedation, without any assistance. And so it's a really good tool. The downsides, so there's the radiation issue, which quite honestly in the workup of dementia in this age group, it's not a study that people are going to get over and over again. The head is not a very radiosensitive area, as opposed to, radiating the breasts or radiating the thyroid gland. And so and we've reduced the radiation from CT based on a lot of the new technology, new algorithms. So I don't think the radiation risk is a huge barrier or consideration here. That being said, what would I want my family member, my grandmother, to get? As you can see from the images that I've shown, the MRIs just show everything a little nicer. I think that's why there's generally a preference to doing MRI. The MRI, and I'll spell out these specific indications. So I showed prion disease in that last case. That's something we just wouldn't be able to see on a CT scan, right? So if you've got a specific diagnosis or worry that there's a specific diagnosis, these others, progressive supranuclear palsy, multisystem atrophy, Huntington's disease, corticobasal degeneration, cerebral autosomal dominant arteriopathy with subacute infarctions and leukoencephalopathy, CADASIL. We're going to see all these way better on an MRI than a CT. So I think you're sort of better off with an MRI, but if a patient, it's hard for a patient to cooperate or tolerate a long examination, if cost is a consideration, if you just want sort of a easier access to something, MRIs they tend to have a little less availability. CT is still a really good test for sort of looking at most of the things that I've shown that are frankly the common diagnoses. And then in terms of contrast or not giving IV contrast, I'd say my sort of biggest pet peeve in reading studies is seeing a dementia workup with contrast. And one, it's because it's really not necessary for any of the diagnoses that we're looking for. And then secondly, it makes me wonder, am I missing something? Was there some other diagnosis, such as they've got a cancer diagnosis and now I'm potentially worried that I'm missing, cancer lesions, but I just wasn't given that history. And so, if somebody does have a known malignancy or there's a really compelling other reason to give contrast, that's fine, but specifically for the workup of dementia, in my opinion, there's really no need for it. If you're going to be giving contrast, I would go the MRI route. You're going to be able to see things much more sensitively on MRI, including contrast enhancing lesions. So if you're going to go through the trouble of giving contrast, do an MRI. But again, it's really not necessary for most indications. Last slide, and then I'll be, I think we're almost out of time here. But so again, we can't predict cognitive function based on the imaging, but we are able to see some of the common ones really well: Alzheimer's, vascular dementia. There's some surgically treatable ones that we're looking out for: subdural hematomas, normal pressure hydrocephalus, and mass lesions. And then there's a handful of very specific ones that we'll see better on MRI, such as prion disease, Huntington's disease, progressive supranuclear palsy, some others. And I will go to the evaluation slide.
We'll leave that evaluation slide up, and thank you so much for a great presentation. You do have a question in the chat from Dr. Parker, who's asking, so oftentimes you get a Happy Meal, you order something, and what is it that we're getting when we're ordering the dementia protocol for an MRI, for example?
So our standard dementia protocol is without contrast. What we're getting is a sagittal volumetric T1 weighted sequence, which we can reformat into a thin coronal plane and axial plane. You're getting an axial T2 flare to look at the white matter lesions, an axial T2 gradient echo to look for microhemorrhages, an axial standard T2, which helps us look at the bone marrow, sinuses, tympanomastoid cavities, flow voids, things like that. And then an axial T1. Did I miss anything? No, that's it. That's it. So it's actually a relatively quick scan, about 15 minutes altogether, without contrast, and it really answers almost everything you can think of in terms of a dementia workup.
Great. 2 quick comments in the chat. When told that there is shrinkage in the area of the brain related to gait, what part of the brain could that be located in?
Related to gait, I typically think of that, and I know there's some neurologists on the call here. I'm looking at the cerebellum to see if there's any cerebellar atrophy for a variety of reasons. Gait abnormalities, you can see that in NPH. So looking for stretching of adjacent white matter tracts from the ventricles blowing up.
Great, thanks for that answer. And Dr. Hales wrote earlier, although rare, this also highlights the importance of always making sure to review all the sequences when evaluating patients: flare, T1, GRE, susceptibility for blood diffusion, et cetera. Sometimes we see incidental strokes as well as when ordering MRIs for dementia evaluation. Thanks for that comment.
Yes, and so I left out diffusion from the standard dementia protocol. That was the one I left out. So looking for incidental strokes.
That sounds great. Perfect. Lori, I wanted to turn it over to you to help us sign out. A round of applause for our speaker today. Really appreciate you. That was awesome.
Yes, thank you so much.